right, let's keep on time. Topic 2, screening early detection. Shelley, take it away.
All right, so I would like to introduce the first speaker, Dr. Nicolas Wentzensen, who's a senior investigator at the National Cancer Institute in the Division of Cancer Epidemiology and Genetics, Hormonal and Reproductive Epidemiology branch. And Dr. Wentzensen is a cancer epidemiologist studying ovarian cancer.
Thank you very much, Shelley. Thanks a lot for, can you hear me? Okay. For inviting me here. I am employed by the National Cancer Institute, but what I'm talking about today is my own personal opinion and not official NCI statements, I have to say that. So we have heard a lot about the heterogeneity of ovarian cancer today. This is the model that is in constant flux and changes every day with new exciting findings. And what we as epidemiologists and public health people would like to address the early steps and see where we could prevent development of ovarian cancer. We would like to know more about the precursor lesions here. But the only thing that we have really solid data on in large studies is that last step. We know that ovarian cancers are very heterogeneous in their histologic presentation. And this is kind of a current model that we can expand and work on with different cells of origin, precursor lesions, and then histologic subtypes. So this is what I'm going to focus today on, and I'm going to present some recently produced data on risk factors and biomarkers from mainly epidemiologic studies. So just briefly to look at the endpoints that I'm going to talk about. There are a number of histologic subtypes that have been well characterized over decades, and those are represented here with serous, the far most common subtype, followed by endometrioid, mucinous, and clear cell. They clearly look very different, and they also come in different grades shown here. This is all based on the most recent edition of SEER of the US Cancer Registry data, looking at the cases that were submitted and looking at the histology and the grading. So most of the serous cancers are high grade, very few are low grade, and then there's a distinct distribution of grades for each of the subtypes. It's important to know that the reproducibility of the histologic subtypes is actually quite good when done by expert pathologists, while the reproducibility of grade is much worse than that. Those are studies, one from a Canadian group led by Martin Kobel, and then a study using tissues from SEER using a panel of US pathologists. So those are the endpoints that I'm going to focus on today. And of course, the question for a long time has been, are there differences in risk factor associations and biomarkers by histologic subtypes? And there have been a lot of individual studies, like this one from our group, looking in a really large cohort study, the NIH ARP cohort, with that has a lot of ovarian cancer endpoints. And we saw that there are heterogeneous associations for some of the key risk factors for ovarian cancer if you look at the individual subtypes. But you also see that the numbers for the non-serous subtypes are very low, even in this really large cohort. There have been very similar results published by Shelley's group from the Nurses' Health Study and a few other studies, the European EPIC cohort and others, but all have run into the same limitations that non-serous subtypes are very rare and we cannot really study them well in individual cohort studies. And so a couple of years ago, we got together, and Shelley and us and our group at the NCI, and we decided to bring together cohorts and establish an ovarian cancer cohort consortium that would allow us to study risk factor associations and, even more importantly, prospective biomarkers with good power and also with the ability to look in much more detail into the ovarian cancer subtypes. And it has gone really well. We now have, I think, more than 20 cohorts in the OC3 This is the logo that Shelley's sister designed, which is really beautiful. This is a great consortium that is very collaborative, very optimistic, very young. We're just starting to get the first paper out. We have a good number of ovarian cancer cases, and remember, those are all prospective cases. So compared to what Simon showed earlier, those were a lot of case control studies, clinical series, where we cannot really look into prospective biomarkers. So this is what we started, and I'm going to briefly go through our first analysis where we evaluated the established ovarian cancer risk factors, now stratified by ovarian cancer subtype with much more decent power than we had before in individual studies. And it was very striking that we saw substantial heterogeneity for almost all the risk factors that we looked at. And I'm going to briefly go through those. Parity, shown here, very heterogeneous, most strongly associated with clear cell and endometrioid. Breastfeeding, not so much. OCUs, very heterogeneous, where we didn't see anything with mucinous, but strong associations with serous, clear cell and endometrioid. Tubal ligation, most strongly associated with clear cell cancers, which makes a lot of sense, thinking about the potential origin somewhere more downstream of the ovary. So if we take away that path, we would expect protection. Age-at menarche, again, most strongly associated with clear cell cancers, not at all with serous in this large study. Age-at menopause, heterogeneous, most strongly, again, with endometrioid and clear cell, and so on. So we looked at all the established risk factors, and for almost all of them, we saw significant heterogeneity and very different findings, and also different directions for individual subtypes, which is quite striking. So the first slide was the hormonal reproductive risk factors. This is other established risk factors like hysterectomy, again, most strongly associated with clear cell cancers, where it appears to be protective. Then family history of breast cancer, strong association with endometrial cancer and somewhat with serous, not the other subtypes. Ovarian cancer, most strongly associated with serous cancers, as we heard before. That makes a lot of sense, but not so much with the other types. BMI, the only significant association we observed was for endometrioid cancers, which makes sense if we think of it as somewhat related to endometrial cancer, where BMI has the strongest association. This is an association that was really not picked up in earlier studies that looked at all the risk factors together, and it's a very specific endometrioid finding. And finally, smoking with very different directions. Again, we see an association with mucinous cancers that has been known before. We see a very strong inverse association with clear cell cancers. Again, we know that smoking is inversely associated with endometrial cancer, and those are interesting findings that we now have to put together into the disease models. So this is just putting it all together in one figure, because looking at all those tables is difficult. And what we did here is we took the individual associations and put them into an unsupervised hierarchical cluster algorithm, and this is what it shows. It shows that we have risk factors that are associated with a risk reduction in green, and those with a risk increase in red. And you see that there's a very heterogeneous picture. If you look at all the 4 subtypes, you see that endometrioid and clear cell are grouped closer together, and then serous and mucinous are separated out. And one of the most striking results, I think, is that almost all risk factors are weakest for the serous cancers, for the most clinically important cancers that we would really like to find ways to detect better and to predict better. And so I think this is a unique kind of summary view of all the established risk factors that makes use of the strength of this consortium. So moving forward, we want to use the consortium to evaluate risk prediction models using those risk factors, and there are a number of risk prediction models already out there that do not really account for heterogeneity of ovarian cancer. So one important question here is what happens if we integrate the subtypes into risk prediction models. And we know that so far risk prediction models have not been very successful at predicting clinically important risks. They're on a way there, and there's a lot of work going on with adding SNPs to those, as we heard from Simon. And this is something we can do here as well, and we can focus on subtype-specific associations. So beyond that, I want to briefly talk about a few other risk factors. And one important area that has gained a lot of interest over the recent years, but with a theory that has been around for a long time, is the role of inflammation in ovarian cancer. And again, we have a number of interesting findings just from recent years showing that nonsteroidal anti-inflammatory drug use, especially aspirin use, is associated with an inverse, has an inverse association with ovarian cancer risk. And this is a study that we did in the OCAC, in the Ovarian Cancer Association Consortium, a few years ago, where we had really large numbers, and we could show that the strongest risk reduction was observed for a regular use pattern. Daily low-dose aspirin led to over 30% risk reduction in that study. And those associations, again, were restricted to serous and endometrioid cancer, so there is a subtype pattern here as well. Endometriosis has long been known as a risk factor of ovarian cancer, and again, this is another study from OCAC making use of that large case control consortium, showing that the associations with endometriosis, the increased risk is restricted to clear cell endometrioid and low-grade serous cancer, so no real association with serous cancers. And finally, there's an ongoing debate about talc use and its role in ovarian cancer. There's a lot of back and forth, and we still don't have a final word on this. There's some recent interesting data from Dan Kramer that he shared showing that the associations that he observes in his case control study are restricted to serous and endometrioid cancers, and this is interesting because it could support like a subtype-specific association can support those findings. If you are worried about reporting bias, you wouldn't expect associations with a specific subtype. So moving away from the risk factors, and briefly two examples of biomarkers. This is again in the same domain, in the domain of inflammation. We conducted a small study in the PLCO trial that you hear a lot more about from Chris Burke in a moment. We looked at, following up on the interesting findings on inflammation, we looked at a Luminex panel of over 60 inflammation markers in pre-diagnostic serum, and we evaluated whether there was some prospective association with ovarian cancer risk, and we found 3 markers that were associated with ovarian cancer in the overall analysis. Stratifying this again by serous versus non-serous cases, we saw different patterns for individual markers. Again, we see one CRP that is more strongly associated with serous cancers, IL-8 more strongly associated with serous cancers, and then TNF-alpha that is much more strongly associated with non-serous cancer. Again, showing we have those different patterns, and if we look at all ovarian cancers together, we always see some kind of an average, and sometimes the average doesn't even appear to be interesting, but if we look at the subtypes, it becomes more instructive. And I think this is early data. We need to replicate that in larger studies, and the Ovarian Cancer Code Consortium is a great place to do that. I want to close with another example of biomarkers, looking at endogenous estrogens and metabolites in ovarian cancer risk. We know a lot of hormonal risk factors that have strong associations with ovarian cancers, but prior attempts to evaluate endogenous estrogens have not really shown associations with ovarian cancer. And we, at the NCI, we have developed an assay that allows quantification of 15 estrogens and metabolites using LCMS. and that allows to really give us a comprehensive picture of endogenous circulating estrogens and their metabolites shown here. And this is very fresh data, just hot off the press last week. But I want to share it with you because it, again, shows the same pattern. Now, if we look at all cases combined, and this is a prospective study nested in the Women's Health Initiative in the observational study component there, we did not see a significant association with ovarian cancer risk, as you see here, although there are some indications that there might be increased risk. And this is just pulling out combinations of pathways. I don't want to show you all 15 individual analytes, but the picture is very similar. But if we stratify again for serous by non-serous cancers, we see a really strong association for most of those estrogens and metabolites for the non-serous cancers, and really not much going on for the serous cancers. Again, we're still working on those data, but we hope to get them out in the public very soon. But this matches what we have observed for a lot of the hormonal risk factors that are more strongly associated with the non-serous cases. And now we have a biomarker that shows up kind of in the same direction. And this difference here and this strong or this lack of association in serous cancers probably explains why in previous smaller studies we didn't see any association. So I'm going to close just saying that there is absolute substantial heterogeneity of risk factor and biomarker associations by ovarian cancer subtypes. And those findings support what we heard before about the different biologic pathways and different cells of origin. We need large studies, and we need to do those analysis by subtypes because we have different directions, and some of those findings might be masked if we put them all together. And of course, this heterogeneity makes risk prediction much more challenging, and we're just kind of beginning to really disentangle that, and maybe we can predict clear cell really well, but we have a big problem predicting serous cancers, and that's something we have to consider when we talk about prevention and risk prediction. And finally, we need to put all those findings together, the risk factor associations, the biology and the genetics, and really kind of reassess our model. We heard about the incessant ovulation theory that was established decades ago, but now I think we have to look at subtype-specific models, and we have to see how we can refine those subtypes. Maybe we find molecular markers that predict subtypes better and those pathways better, but I think that's an important message for today. Thank you.